Namaste.
Namaste, Amin Sahib. Good morning.
Amin Sahib, good morning.
Good morning. Good morning.
And Sal Mubarak.
Sal Mubarak.
સાહેબ URTI થયું લાગે છે. So, Rumin, we can start the meeting. So,
Yeah.
We are ready. So, good morning, friends. Welcome back to morning Saturday Morning Club meeting today. And this time we have Dr. Rumin Shah, who has been a regular speaker at our club since very long time. So today he is going to talk to us about the year that was best trials of 2022. To introduce formally Dr. Rumin Shah, he is a consultant senior physician, Vadodara, and is a very popular speaker at various fora. His areas of special interest are diabetes, non-invasive cardiology, hypertension, dyslipidemia, and obesity. He's involved as faculty and organization of academic programs in various associations like IMA, API, etc. And something very special about him is that he's a very avid reader and a very sought-after book reviewer. Earlier also in Saturday Club, he has reviewed very interesting books in past. So Rumin, welcome back to Saturday Club morning meeting. You can go ahead with your talk. Your time is 40-45 minutes and we'll have some discussion of about 10 to 15 minutes. So over to you, Dr. Rumin.
Thank you, Satish. I hope the screen is visible.
Yeah, it is.
Good morning, colleagues. Thank you, Satish, for nice introduction. In next few minutes, I'll be discussing about some of the impact-making trials of 2022. Sorry for that. I'm sorry for that. So what is happening? Okay. Screen is not. Just give me another.
Slides are not moving.
Just it will take another minute. Okay, it is moving.
Yeah, you have a video.
Yeah. So basically, the talk is going to focus on cardiovascular, diabetes, lipids, obesity trials. These are the trials which made high impact as far as the international reviews were concerned. And these are all clinical practice oriented. They made impact for all of us to give better patient care. So this is going to be the flow of the talk, and to go through various relevant trials. I went through some of the journals, some of the high impact articles, and that made the talk possible. Sorry for that. Okay. Sorry. So the format is going to be a brief introduction of the topic, the actual trial, conclusions of the trial, and how is the trial or how are the trial results going to change our treatment. Let us first start with hypertension, a very common disorder. And a major trial which came last year was chronobiology of hypertension, the time trial. Well, this trial was in UK, two giants in the field of hypertension, Brian Williams and Neil Poulter, were part of the trial, and therefore the trial made an interesting outcome. The trial was treatment in morning versus evening in hypertension. Now, what is the basis, or why did they do this trial? Well, way back, once in 2010, and another in 2019, two trials came from Spain, in which there was a major emphasis of giving antihypertensive medication at night, mainly to prevent a morning surge in blood pressure, and therefore to prevent cerebrovascular stroke and coronary artery disease that commonly occurs in morning hours. These two trials, which came from Spain, very well emphasize that all patients of hypertension must get one tablet, at least one dose of antihypertensive medication at night. And these were very high impact trials, HYGEA trial and MAPEC trial. So basically the idea is that when you give a blood pressure medication at bedtime, there is significant lowering of blood pressure at night without loss of awake BP lowering efficacy. There is a significant lower prevalence of non-dipping, the dipping that occurs at night. And therefore, it was recommended that when you give one drug at night, there is a 61% reduction in cardiovascular deaths and 67% reduction in major events as per the past trials. Now, this, and therefore, the Asian guidelines, which were published in 2022, clearly recommended that our goal in treating blood pressure should be to reduce morning blood pressure, and therefore all of our patients should get at least one tablet at night. And on this background, this trial assumes significance. So this trial, which came from UK and followed the patient for almost 10 years, two groups, patients were on morning dose, the other group was on evening dose. And at the end of the trial, they found out that when you compare morning versus evening dose of the blood pressure medication, there was absolutely no difference in composite outcomes of vascular death, hospitalization, non-fatal infarction, stroke, up to 5.2 years. There was no difference in all-cause mortality, and taking medication in the evening was not harmful, but it had no additional benefit. And therefore, the trial recommended that patients should be advised not to change their antihypertensive medication dosing time and choose to take their medication at time that suits them best, as timing of antihypertensive medication makes no difference to cardiovascular outcomes. The trial suggested that dosing time should not be a significant consideration. Rather than that, clinicians should focus more on selecting appropriate medication, and we should seek that patient strictly adhere to the medication. The message from time trial is very clear that as far as antihypertensive medication is concerned, dosing time, whether morning, evening, noon, is not at all an issue. And we should, as clinicians, should rather focus on enforcing the appropriate intake of medication and adherence. The second major trial was renal artery denervation in management of hypertension, Simplicity Hypertension 3 trial. A brief background of what this means. It is believed that sympathetic nervous system, afferent nerves supplying kidneys, play a major role in genesis of hypertension by increasing renin release and creating activation of renin-angiotensin system. And therefore, when you work on this renal afferent nerves and when you do denervation, there is going to be a long-term effect on blood pressure. And this concept of management of hypertension with renal denervation was first sort of first time came into existence in 2002. And then there were articles from 2010 onwards in which it was seen that this therapy does not give major benefits to patients of hypertension when this treatment is offered as an option for resistant hypertension. There were major trials from centers in Germany which showed that the trial is not effective. And therefore, this was a trial which was published in Lancet. Two great cardiologists of the time, Deepak Bhatt and George Bakris, were the co-authors. And this trial followed the patient for almost 3 years after renal sympathetic denervation. And what did the trial show? That the office blood pressure, that is the blood pressure that we measure in patient, there was a 26 millimeter reduction in blood pressure in renal sympathetic now group. And if you look at ambulatory blood pressure, the 24-hour blood pressure, there was 15.6 millimeter reduction in blood pressure, showing that renal sympathetic denervation at the end of 3 years gave excellent results in control of blood pressure. If you look at 24-hour blood pressure, if you look at the red one, which is the sham or the control group, the blue one, which is the renal denervation, at the end of 3 years, there was a significant reduction in both systolic blood pressure in office and systolic blood pressure during 24-hour monitoring, clearly showing that there is a long-term safety and efficacy of catheter-based renal artery denervation in patients with hypertension, mainly in those patients who are on maximum antihypertensive medication. This is a safe procedure. There are no late emerging complications. And there is a meaningful reduction in office, that is the blood pressure that we measure in clinic, and 24-hour systolic and diastolic blood pressure throughout the long-term follow-up of 3 years. There is a remarkable improvement in continuous blood pressure reduction throughout 3 years. And patients who underwent renal artery denervation as management of hypertension spent nearly twice as much time in a therapeutic blood pressure range compared with control group. Therefore, renal artery sympathetic denervation offers a favorable, durable, and safe long-term result in management of blood pressure with large reduction in blood pressure. And this is certainly going to be an additional treatment option for patients with uncontrolled resistant hypertension outside of lifestyle modification and useful despite use of maximally tolerated antihypertensive medication. There are a large number of patients who have resistant hypertension, and many drugs are required permutation combinations leading to side effects, and renal artery sympathetic denervation therefore is going to offer favorable, durable, safe, and larger reduction in blood pressure, long duration of follow-up. This is a new modality of treatment which is going to help our patients in controlling blood pressure very well. The third trial was Precision trial, and this was a new drug which was tried in management of hypertension. Aprocitentan is a dual endothelin antagonist. It works on endothelin 1, and therefore, by blocking it, it causes reduction in endothelial dysfunction. And when this drug was given at a dose of 5 milligram, 10 milligram, up to 50 milligram, there was a remarkable reduction in blood pressure when compared to standard of care lisinopril over a period of almost 6 months. This trial, Precision trial, which again came from lead authors like George Bakris, showed that over a period of 24 hours, there was a remarkable reduction at the end of 40 weeks in both systolic and diastolic blood pressure, daytime blood pressure, and nighttime blood pressure. And therefore, in patients with resistant hypertension, aprocitentan, a dual endothelin receptor antagonist, was well tolerated and superior to placebo in lowering blood pressure at week 4, and the effect lasted till the 40 weeks. This drug represents a novel, effective, and well-tolerated treatment for resistant hypertension. Now, this is a completely new pathophysiological pathway which this drug is offering. And therefore, we have one more group besides angiotensin receptor blockers or RAS inhibitors, calcium channel blockers, beta blockers, and center-acting drugs as a drug of choice in management of resistant hypertension. The takeaway message is that this is a new, effective, and well-tolerated treatment for resistant hypertension. From hypertension, now we move on to ischemic heart disease. We know a patient of chest pain, when the patient comes to us, the ECG is normal. There is always that dilemma what to do. Troponin I is normal. There are fixed, good algorithms and protocols available. But from individual to individual, there is a variation in how to approach the patient depending on comorbidities. A new modality is CT coronary calcium score. This is about the coronary calcium deposited in the coronary arteries. And there is a scoring system in which patients are divided into minimal risk, mild risk, moderate risk, and high risk just by doing a CT calcium score. Now, this trial was coronary calcium score to rule out obstructive coronary artery disease in patients with acute chest pain. Lead author was a principal investigator was Gautam Gandhi. And if you look at this, the trial showed that this is a test which is very easy to perform and interpret. The costs are lower. No contrast is necessary. It prevents unnecessary testing. The radiation exposure is minimal and it is widely available. And if you look the results, when patients of chest pain were admitted, 56% of them had coronary artery calcium score 0. And all those who had a 0 calcium score, there was a very, very low likelihood of an obstructive coronary artery disease. Only 1 in 20 had even minor coronary artery disease. 1 in 100 had obstructive coronary artery disease, and 1 in 200 required revascularization, showing that in a coronary artery calcium score can be used as a gatekeeper for further cardiac testing, whether to send the patient for an angiography invasive or further test to exclude obstructive coronary artery disease in patients at low to intermediate risk of acute coronary syndrome. And therefore, in a patient of chest pain, early coronary artery testing, coronary artery calcium testing is a good option before deciding about invasive procedure, before deciding about further aggressive intervention. Another trial, comparison of different investigation in strategies to defer cardiac testing in patients with stable chest pain. This was a trial from Korea, and in this trial, again, coronary artery calcium-based strategy, especially combining coronary artery calcium with pre-test probability, that is coexistence of comorbidity, a high lipid, a typical chest pain, was very useful in diagnosing patient to have a significant coronary artery, and therefore it is recommended that coronary artery calcium can be used as a gatekeeper before deciding whether patient should undergo an invasive coronary angiography or before deciding whether patient actually requires rest and aggressive treatment or patient can go back to work. This is a very important tool in evaluation of chest pain when there is a clear-cut dilemma, because we know chest pain could be a disaster and it could be an infarct incoming. The third talk is on trials in chronic stable angina. Chronic stable angina, as we know, is a disease which usually requires investigations because patient has exertional angina, and the typical approach right now is to subject the patient to invasive modality, get an angio done, get a revascularization done, get a plastic done, or get a bypass done. And this was a multinational trial, Ischemia Research Group, published in European Heart Journal. And this trial showed that in a large cohort of patients, roughly 5,200 patients, patients were subjected either to invasive strategy, that means an angiography and revascularization. And the other half was subjected to conservative strategy, that means aggressive medical management. And at the end of 5 years, both first primary endpoint event, that is a cardiovascular event, was same in both the groups, whether the patients were on medical treatment or surgical treatment. And there was an extension of this trial known as Ischemia Extend trial, in which it was clearly shown that stable coronary artery patients with moderate or severe myocardial ischemia enrolled in this trial, invasive treatment strategy did not prevent either net recurrent events or net total events more effectively than conservative strategy. That means in a patient of chronic stable angina, aggressive medical management is also going to give equal amount of goal-oriented results. This is another study, Ischemia Extend study, same group, published in, this was published in Circulation, and clearly showed that when you put the patient on conservative management, the outcome at the end of 5.7 years is reasonably good, and there is a feeling of guilt that we did not push the patient for an angiography or for a bypass. But managing these patients aggressively with medication, with risk factor modification, with statin, with aspirin is going to give good results. So depending on the amount of myocardium involvement and depending on the symptoms, patient can very well be put on non-invasive, strong medications, aggressive lifestyle modification, and will give good results. Now, if you look at this trial, heart failure trials, I'll come to heart failure trials after angina. Heart failure has rightly been labeled as the burden of current plague. It has been labeled as a current plague. There is a huge epidemic of heart failure. There is a changing pattern of hypertension, heart failure, secondary to diseases like hypertension and coronary disease, and the prognosis is bad as a malignancy. Just for refreshing, heart failure is now divided into heart failure with reduced ejection fraction. That is what we have been treating so far, in which the ejection fraction is below 40%. Then there are patients who have mid-range ejection fraction between 41 to 49%. And there is an entity or subset of heart failure, which is known as heart failure with preserved ejection fraction, in which patients have heart failure, symptoms and signs of heart failure, but the ejection fraction is above 50%. If you look at the epidemiology of heart failure over a period of time, all over the world, there is a higher prevalence of heart failure with preserved ejection fraction. That means the patient has heart failure, but there is a higher incidence of good ejection fraction above 50%. This is more common in females, common in elderly, more in those who have long-standing hypertension or atrial fibrillation. Standard treatment for heart failure has been known as 4 pillars of heart failure: the angiotensin receptor and neprilysin inhibitor, beta blocker, mineralocorticoid receptor agonist, and SGLT2 inhibitors. Now, in this trial, these patients were put on SGLT2 inhibitors, but mind you, these were patients who had heart failure with preserved ejection fraction. So first trial was DELIVER trial, dapagliflozin. In this trial, patients of heart failure with preserved ejection fraction were put on dapagliflozin. And at the end of almost 3 years, there was a remarkable 18% reduction in primary outcome, 6% reduction in death from any cause, and 12% reduction in death from cardiovascular cause. So, among patients with heart failure and preserved ejection fraction, dapagliflozin or SGLT2 inhibitor resulted in a lower risk of primary composite outcome, and therefore, irrespective of presence or absence of diabetes, SGLT2 inhibitors are indicated in management of heart failure, irrespective of presence or absence of diabetes and irrespective of their ejection fraction. Another HF pooled trial showed that there was a 5 to 16% reduction in primary outcome of cardiovascular death and morbidity when patients were put on dapagliflozin, even though they had normal glycemic, that means they did not have diabetes, and their ejection fraction was low, was normal. And irrespective of low or high ejection fraction, irrespective of diabetes, dapagliflozin gives good results in primary outcome. And if you look at ejection fraction, whether it was 20% or 60%, the patients had remarkable improvement in death from heart failure when they were put on dapagliflozin. And therefore, across the full spectrum of ejection fraction, almost 20% to 70%, dapagliflozin significantly reduced the risk of CV death. The same group, dapagliflozin, another SGLT2 inhibitor, was tried in EMPEROR-2 trial. And again, it showed that at the end of 3 years, compared to placebo, there was a 21% reduction in cardiovascular risk and 22% reduction in heart failure hospitalization. There was a 27% reduction in first heart failure hospitalization and 26% reduction in recurrent heart failure hospitalization. So even irrespective of A1C level, whether patient had diabetes or no diabetes. And look at these patients whose A1C was less than 7%. Large cohort of patients who had normal glycemic control, no diabetes, they benefited immensely with empagliflozin when they were put on EMPA for management of heart failure with preserved ejection fraction. This trial concluded that empagliflozin provides consistent benefits across the spectrum of chronic heart failure, regardless of presence of diabetes and irrespective of their ejection fraction. If you look at those patients, even when the ejection fraction was 25% or ejection fraction was 65%, there was a reduction in heart failure hospitalization and reduction in recurrence of heart failure hospitalization. Now, why is this important? In the past, heart failure with reduced ejection fraction has been treated with various drugs and has given good results with various drugs. As compared to that, there were no drugs which showed benefits in heart failure with preserved ejection fraction. Beta blockers, calcium channel blockers, ARBs, ARNIs, everything has been tried, nothing gave results. It is only and only SGLT2 inhibitors which help in patients of heart failure with preserved ejection fraction by working on oxidative stress, reducing inflammation, reducing fibrosis, and hypertrophy. So, SGLT2 inhibition by reducing sympathetic nervous system, reducing inflammation, reducing renin-angiotensin activity, and oxidative stress is useful in heart failure with reduced as well as preserved ejection fraction. If you look at heart failure with preserved ejection fraction is a disease of growing incidence, there have been no significant beneficial treatment for this disease. And treatment was focused on symptom control rather than improving morbidity or improving lifespan. And SGLT2 inhibitors provide the first promising treatment option for heart failure with preserved ejection fraction, following EMPEROR and the dapagliflozin. Another trial was empagliflozin decompensated heart failure. These are patients who are admitted in ICU with acute heart failure, and there were three publications: Circulation, Nature Medicine, and European Society of Cardiology, showing the effect of empagliflozin started on day 1 in patients admitted with acute decompensated heart failure. And if you look, there was a remarkable improvement in all these patients when they were given empagliflozin on admission for acute heart failure. Acute heart failure, as we know, is a disastrous thing, high mortality, long ICU stay, and presence of comorbidities. So the conclusion was that initiation of empagliflozin in patients hospitalized for acute heart failure produced clinical benefit regardless of degree of symptomatic improvement at baseline and despite the presence or absence of comorbidity at the end of 90 days as well. Now, if you look at patients of heart failure with reduced ejection fraction, that's what we have been treating for years. Now, this group of drug, SGLT2 inhibitors, work across the spectrum in patients with reduced ejection fraction, mid-range ejection fraction, and normal ejection fraction. This is the first group of drug which has been recommended for management of patients of heart failure with preserved ejection fraction. So across the spectrum of heart failure, whether prevention, reduced ejection fraction, preserved ejection fraction, acute failure, post-MI, SGLT2 inhibitor therapy remains a first-line treatment in managing this patient, and therefore, the conclusion is that dapagliflozin or empagliflozin remains essential therapy in all patients having heart failure, regardless of presence or absence of type 2 diabetes, because basically these are drugs used in management of diabetes or left ventricular ejection fraction, low or high, as well as in acute decompensated heart failure. And therefore, Eugene Braunwald, the great cardiologist, has written this editorial in which he says that SGLT2 inhibitors are the statins of the 21st century, and no patient of heart failure should be deprived of the benefits of SGLT2 inhibitors, whether they have diabetes or not. A large trial on heart failure is ADVERT trial, in which an old drug, acetazolamide, was used in acute decompensated heart failure with volume overload.
Rumin, stop. Sorry to disturb you. Sorry to disturb you in your speech. I want to know whether the dose of gliflozin HEPA or EMPA in a diabetic and non-diabetic for the treatment of heart failure differs.
No,
And
it
what
is
dose
same.
would you recommend?
It is same. There is no reduction of dose in non-diabetic because there is no clinical hypoglycemia because these are anti-hyperglycemic medication. So they don't cause hyperglycemia. They cause reduction in blood sugar, but there is no clinical hypoglycemia in such patient. So irrespective of status of diabetes, the dose remains same.
What dose would you recommend?
So 10 milligrams of empagliflozin to start with, going to 25 milligram, 5 milligram of DAPA to start with, and going to 10 milligram of dapagliflozin.
Thank you very much, Arvind. Thank you.
So this was
Atul and
another
all
trial.
others. Atul and all others, please. We will have a time for discussion of 10-15 minutes at the end of the talk so that he can finish in time and then we will have time for discussion. So please hold back your questions.
Sorry,
Put them on
Satish.
the
Sorry,
chat box.
Satish. I wouldn't be doing it. Sorry, Satish.
No, it's okay. But put it on the chat box and at the end of his talk, now we'll take up all the questions.
Thank you. Thank you.
Thank you, Atul. Thank you.
This was a trial from Belgium in which an old molecule, acetazolamide, which have been using a lot, Diamox, more used by ophthalmologists and as for mountain sickness, was used in management of heart failure. And it showed remarkable improvement, 46% reduction in endpoints. This was the largest diuretic therapy trial in acute heart failure. Large number of patients had comorbidities. Although this is a drug which has been used for mountain sickness and glaucoma, this drug, when given intravenously, showed a remarkable improvement in decongestion in patients hospitalized for heart failure. And the editorial said that from the management of altitude sickness to treatment of congestion in acute heart failure, a new season for acetazolamide. Therefore, acetazolamide addition to loop diuretic therapy in patients with acute decompensated heart failure results in greater incidence of successful decongestion. Now, this acute decompensated heart failure sometimes is a real trouble because we need to monitor so many things, the blood pressure, the comorbidities, and this becomes an additional tool to manage such patients. I go to lipid trials, and a common tendency in all of us is to give very high dose of statin, more so in Indians, whenever there is a presence of high lipids or a coexisting morbidity like coronary artery disease, a cerebrovascular or a peripheral arterial disease. And this therapy showed when patients were put on ezetimibe. Ezetimibe, as is well known, is a drug which stops absorption of lipids from GIT. So far, the drug has been used more as a spare wheel. Hardly ever used when there was no option available and was sort of relegated in dustbin. Now, this trial, which was published from China and had a large population, Southeast Asia population, showed that moderate intensity statin with ezetimibe therapy was very useful and was non-inferior to high intensity statin therapy when given for 3 years. Now, why is it important? Because when you give high intensity statin, there are complications like leg pains, high SCPT, intolerance, and so on. Adding ezetimibe will reduce these side effects and would be a good tool to start with in a patient of either severe morbidity and dyslipidemia or pure dyslipidemia. The racing trial, therefore, concludes that the addition of ezetimibe for patients who are taking moderate intensity statin at a maximal tolerated dose should be used earlier rather than doubling statin dose or statin intolerance. And this therapy has a future and should be used more frequently than just using statin therapy. And in another article, it has been clearly mentioned, this is an article written by Kaushik Ray, that when a patient comes to you, don't just start with statin, start with a combination of statin and ezetimibe as early as possible, just like we start combination therapy in tuberculosis or diabetes. And now there is a clear-cut indication that over a period of time, ezetimibe is going to play a major role in management of dyslipidemia in addition to statin therapy. Interesting trial was intermittent fasting. We see a lot of patients who now go for intermittent fasting, which could be 16 hours fasting, 18 hours fasting, 12 hours fasting. And people come with legendary or anecdotal evidence that they have lost weight. It has some physiological benefits that it reduces obesity, it reduces some hormones, and it has long-term good outcome in managing weight and cardiovascular morbidity and mortality because of reduction in oxidative stress, improvement in circadian rhythm, genesis of ketotic state. Now, this trial was time-restricted eating trial in which patients were put on time-restricted eating or regular eating. That means you could eat anytime, but restriction of calories. And this trial clearly showed that in patients of obesity, daily caloric restriction is as good as time-restricted eating. And time-restricted eating, that is intermittent fasting, 18-6, 12-12, or 12 or 16-8, offered no weight loss benefit as compared to caloric restrictions alone. So, if further trials come, we should be very clear that management of patient who comes to us for advice of intermittent fasting, we can ask them to follow. If you look at the results of trial, there was no significant weight change at the end of 12 months. And the trial concluded that among patients with obesity, daily caloric restriction was not inferior to time-restricted eating in management of obesity. A quick look at diabetic trials. There are two trials reported in New England Journal of Medicine. Great trial. One was which drug to start in a patient of diabetes. Patients were after metformin put on either insulin, glimepiride, liraglutide, or sitagliptin, and they were followed up for a long period of time. So there is a dilemma: which should be the second drug? And if you look at the outcome, all four medications, whether you add glargine, insulin, liraglutide, a GLP-1 analog, or metformin, or glimepiride or sitagliptin, the glycated hemoglobin went down. However, injectables like glargine and liraglutide, as is well known, were significantly more effective in achieving targeted glycosylated hemoglobin level. Therefore, in a patient who is put on metformin and you want good results, put the patient on either insulin or GLP-1 analog. If you want good results, quick results. However, if you look at the second part of the study, the GRADE study, effect on microvascular and cardiovascular outcomes in patients who were put on the four group of drugs. So, four patients after metformin were put on glargine, glimepiride, liraglutide, sitagliptin. As is well known, glimepiride is sulfonylurea, sitagliptin is DPP-4 inhibitor, and it showed that at the end of 6 years, there was no change in the microvascular complication. Therefore, in the trial clearly showed that in patients of type 2 diabetes, the incidence of microvascular complication and death did not differ at the end of 4 or 5 years when patients were put on any group of drugs. And therefore, although glycemic control was better with injectables, when there is a dilemma whether to start sulfonylurea, a gliptin, or glargine, you could start any of them to get good glycemic control, and rest assured that the microvascular complications are going to be low. Another important trial was of a new drug called Finerenone in management of cardiovascular and kidney outcomes with Finerenone in patients with type 2 diabetes and chronic kidney disease. Now, this is a drug which Finerenone is like aldosterone, eplerenone, a mineralocorticoid receptor antagonist, and that drug, Finerenone, is a bulky non-steroidal molecule, exhibits anti-fibrotic and anti-inflammatory activity. And when patients of type 2 diabetes with kidney disease, and there is a huge surge in this group of patients, were put on Finerenone 10 milligram or 20 milligram, over a period of time, there was a remarkable improvement in cardiovascular and kidney outcome, with a caveat of a few patients getting hyperkalemia. So these patients who are diabetic and have some amount of kidney involvement would benefit immensely from Finerenone. Just need to monitor potassium in such patients. The last part of my talk is going to be on something very interesting, and that is known as twin creatine therapy. Sorry for that. We all know what is incretin therapy. So we have DPP-4 inhibitors, sitagliptin, vildagliptin, Sexa, Alo, Lina, teneligliptin, which we have been using for last 10 years. And we have GLP-1 analogs like exenatide, liraglutide, and semaglutide, which we have been using for last 4 or 5 years. Now, incretins are gastrointestinal hormones that simulate insulin secretion at physiological concentration. And there is an evaluation of incretin therapy which was proposed in 1906, and now they are full-fledged part of treatment of diabetes in 2020, giving excellent results in glycemic control and some more additional benefits. If you look at GLP-1 receptor antagonists, they work, reduce satiety, improve insulin secretion, reduce gastric emptying, reduce hyperglycemia. And on central nervous system, again, there are effects like reduction in food intake with GIP antagonism. Now, a drug which works on both, so far we have drugs which used to work only on GLP-1. Now we have a drug which works on both GLP-1 and GIP-1 receptor. And sorry for that. This drug, tirzepatide, is an amino acid and works on both GLP-1 and GIP. I showed you this is GLP-1 and this is GIP. So far we have drugs only working on GLP-1. Now we have drugs working on GLP-1 and GIP both. Now these drugs, when given to a patient of diabetes, because it decreases food intake, decreases appetite, increases weight loss, increases insulin secretion and synthesis, increases lipolysis, reduction in beta cell apoptosis, the drug gives wonderful results in diabetes. There are 4 trials, SURPASS-1, SURPASS-2, SURPASS-3, and SURPASS-4, in which this drug was tried purely for management of diabetes and compared with various other agents like semaglutide, insulin, and as a first-line treatment. And it showed remarkable improvement in control of blood sugar. So when it was compared with insulin, there was a remarkable improvement in glycemia when 5 milligram or 10 milligram tirzepatide was given once a week, thus establishing the role of this drug as anti-hyperglycemic drug or anti-diabetic drug. The beauty now lies here. This drug, when was given, as we saw, there was a reduction in fasting blood sugar, reduction in A1C, reduction in PP2. But the beauty comes now. This drug, when used in type 2 diabetes compared to insulin glargine, showed a remarkable improvement in glycemic control with reduction in weight. 4 trials, 1, 2, 3, 4, showed the efficacy of this drug. The most important trial was obesity trial. We all know obesity is now a pandemic. And even in India, there is a huge number of obesity. This paper says that over a period of time, from 1980 to 2030, there is a reduction in A1C all over the world. That means the glycemic control has improved, but the BMI has gone up. So we have less diabetic complications because good control of diabetes, but obesity is increasing. And we need a drug. And this drug, which is used for diabetes, tirzepatide, was used for management of obesity. There were 4 trials, SURMOUNT 1, 2, 3, 4. SURMOUNT 1 reports came out, and this drug, when given a dose of 15 milligram, showed remarkable reduction in weight. The reduction in weight was as high as 20 kilo. No drug in world so far has given a weight reduction as high as 24 kilo at 72 weeks. This is as good as bariatric surgery. If you look at whether patient was very obese or obese, 90% patients achieved more than 5% weight loss, almost 50% achieved more than 20% weight loss, and more than 1/3 patients achieved 25%, more than 25% weight reduction. If you look at weight reduction, more patients achieved a very good weight reduction to the tune of 63% in some cases. There was a change in fat mass. Patient had 3 times higher reduction in fat mass than lean mass, showing the effects of this drug on lipids. This trial now clearly shows that patients who are put on tirzepatide show remarkable improvement in weight reduction, and this reduction in weight is not seen with any other medication. So all tirzepatide doses, 5 milligram, 10 milligram, 15 milligram, demonstrated superior, clinically meaningful and sustained body weight reduction. More patients in tirzepatide group achieved weight loss of more than 10, 15, and 20%. There were side effects, GI side effects, but most of the cardiometabolic risk factors like blood pressure, like lipids and vascular endothelial function improved with this drug. So, quinquetin therapy, that is tirzepatide, a dual GLP-GIP blocker, demonstrates superior clinically meaningful glycemic control and sustained body weight reduction versus placebo. More patients achieved a higher weight loss, some to the tune of 24 kilo, and all parameters showed remarkable improvement. Clearly, tirzepatide is the molecule of next decade, giving us superior results not only in diabetes control but also in control of obesity. I thank you so much for your patient listening. If there are any questions, I would be pleased to answer.
Thank you, Dr. Rumin. That was excellent. You may stop the screen sharing now.
Right.
Some of you who know Dr. Rumin, he's a marathon runner also. And this was a marathon presentation, I would say. Wonderful presentation, Rumin. We can see how much pains you have taken to put up all these recent studies together and giving out very crisp carry-home messages. So thank you so much. First, we start with a question in the chat box. Let me see. Yeah, there is one question from Dr. Pradeep. Good morning, sir. What is the mechanism of action of SGLT2 inhibitors in heart failure? Only through renal clearance of fluid? What about after load reduction? Yeah, that is a question.
So, I have shown that in slide. Give me a minute to show the slide. The effect of SGLT2 inhibitors. Just give me another minute. I'll show what is the. Okay. SGLT2 inhibitors work at various levels, and therefore, another minute. So, SGLT2 inhibitors work at various levels in management of heart failure and in giving beneficial effects in patients of heart failure. And just give me one. I need to show that. Well, there is a reduction in oxidative stress. There is improvement in fibrosis. There is reduction in hypertrophy. There is improvement in diastolic function. There is reduction in renin-angiotensin-aldosterone system. So they just don't work as diuretics. The major effect of SGLT2 inhibitor is washing out sodium and glucose in urine as a part of diabetes control. Now these drugs go beyond that. They just not only remove sodium and glucose from the body and associated fluid, they also work at cellular level, reduce oxidative stress, reduce fibrosis, reduce hypertrophy, and therefore they are useful in heart patient.
Thank you, Rumin, for that quick answer. Now it's open to others. And today, because Rumin is there, now I have my few classmates also present in this meeting. Rumin and there are other classmates of 1976 batch of BMC. Dr. Atul was there. Atul, if you are still there, no, you may interact now. Sorry, I interrupted that time because usually during the talk, we do not ask questions. At the end of the talk, we ask questions. So, Rumin, Atul, you are free to ask any questions now. Any
I think some of the topics need a working discussion for a whole one section Saturday meeting, like tirzepatide, how it works, what are the benefits, etc. So full detailed presentation would be more useful.
I agree. Each of them would require a
yes,
different
one
session.
full presentation. Yes.
The question in chat box, can we give glucagon like peptide injection Victoza to obesity patient with single kidney and creatine of 1.3? We can certainly give it. The drug is reasonably renal safe, is not contraindicated in patients of renal failure, and would give good results. Obviously, I would go on monitoring creatinine, but the only side effect of all GLP-1 analogs is decrease in appetite and severe gastritis. So if the patient can go through that phase, initial phase about a week or 15 days, the drug is very safe even in patients with renal failure or impending or azotemia, so as to say.
Any other questions?
Rumin bhai,
Yes, please.
for tirazoxime to act, can it act on non-diabetic obese patients?
Absolutely, absolutely. It is a drug to be marketed for non-diabetic because GLP-1 analogs are anti-hyperglycemic agents. So the drug in a diabetic causes reduction in sugar. In a non-diabetic, is causes sugar level to go down to normal, but it does not cause hypoglycemia. And that is a drug now. Surprisingly, in USA, the drug is not available for diabetics because there is a huge demand for from obese patients. So the drug has unfortunately been diverted to all obese patients rather than genuinely deserving diabetic patients. So Monjuro, the trade name of this drug, for quite some time was not easily available because of a huge demand by non-diabetic obese patients.
Rumin bhai, the molecule sodium glucose inhibitor requires proper renal function. Renal membrane should be normal for the blocker to function.
So when the drugs were introduced, the first, maybe about 10 years back, the first instruction was that they should never be given in a patient who has poor renal function. Over a period of time, now there is a clear-cut recommendation that up to 30 eGFR, we can safely give SGLT2 inhibitors, DAPA, EMPA in patients. We just need to monitor about electrolyte imbalance, sometimes because there is diuresis in elderly, that could be hyponatremia. And secondly, in a diabetic, there could be a sort of euglycemic ketosis. That means the sugar is normal, but there is a ketosis. So these are the two caveats. Otherwise, the drug can be very well, these drugs, EMPA, dapagliflozin, can be used very well in patients up to eGFR of 30%. And maybe over a period of time, the recommendation of using them up to eGFR of 15% will come.
Thank you.
Any other questions or comments?
I think the role of intermittent fasting was initially more for its role in apoptosis of disease cells. Now these trials for obesity and other things were, as a collateral trial. So still,
Absolutely.
I think intermittent fasting is very important as far as killing of cancer cells or other disease cells are concerned. And the Japanese scientist who got a Nobel Prize for that was only for its role in apoptosis of disease cells.
I completely agree, but this was a very specific subgroup analysis of intermittent fasting in management obesity versus just plain calorie restriction, because intermittent fasting has its own problems in some people. So this trial was used and it showed that purely from the point of view of obesity, restricting calories gives same amount of weight reduction as compared to intermittent fasting. But the other part, for example, cell apoptosis and malignancy, yes, it has a role to play. No questions about it.
Thank you. Rumin, can you say something about vericiguat in heart failure?
Oh, that's a wonderful drug, especially when there is a heart failure. Most of the patients would have low blood pressure, and there are very few options available. You can't give ARNI, high-dose diuretics, or a beta blocker. In such patients, vericiguat gives wonderful results. Keeping the cost apart, in patients who have, for example, bradycardia, a low blood pressure, hypertension, these drugs has given wonderful results. And I forget the name of drug, but it has given very good results in management of acute decompensated heart failure. And as a follow-up in patients who were put on vericiguat, it has given good results over a period of at least 6 months that I know of. But it's a good drug to treat heart failure. The questions from, in a case of PTCA plus diabetes, developing myopathy, rhabdomyolysis, atorvastatin is to be stopped or not? What should be the alternative? Well, if it is clearly related to a statin therapy, and if we prove that statin therapy stoppage for about some time reduces myopathy, then it is clearly related to statin-induced myopathy. I would rather rule out a vitamin D deficiency, a hypocalcemia, a thyroid dysfunction before labeling the patient as statin-induced myopathy or rhabdomyolysis. Now, having proven that patient clearly has a statin myopathy or rhabdomyolysis, I would still give a fair trial of low dose of atorvastatin 1, add coenzyme Q, 2, substitute it with rosuvastatin 5 mg, 3, go down to rosuvastatin 5 mg alternate day 4. If none of them work, then I'll switch over to ezetimibe, or if the patient is affording on the newer drugs, PKSC inhibitor, PCSK inhibitor, but they are very costly.
There is one more question, I think, from Dr. Gopal Agarwal. Can we give glucagon-like peptides injection, Victoza?
I answered that it is safe to be given in patients with single kidney and a creatinine of 1.3 can safely be given.
I think there are no more questions or comments. So thank you once again, Dr. Umin, for excellent, very informative talk. And thank you for all the efforts. We expect you to be back to Saturday Club very soon now. Some more topics.
Thank you. Thank you so much. Thank you, everyone.
Thank you, everyone. So we close the session here.
Thank you so much. Thank you.
And an announcement, next Saturday, we are going to have a physical meeting. Dr. Satish Sai and Dr. Daksha Ben are here. And to relive those memories of physical meeting of Saturday Club every Saturday morning at Dr. Satish Sai's nursing home. I request all of you who have been part of Saturday Club group to come physically at KGP Children Hospital. I'll make a flyer and make an announcement later. It's going to be a physical meeting at KGP Children Hospital, same time, 8 a.m. to 9 a.m. And Dr. Kiran Saha will be presenting synopsis of recently attended API conference. So all of you are requested to come and have a once again those lovely days when we used to meet every Saturday morning for a physical meeting. So I request all of you to come for that meeting. Thank you so much. We end the session here.